Good afternoon, everyone, and welcome to the second session of our Do Health Systems Deliver webinar series. My name is Dr. Khalid Al-Dosri, Health Policy Manager at the Center for Value in Health. In our previous session, we have explored the groundbreaking OECD Patient-Reported Indicator Survey, PARIS, which illuminated key patient-provider insights and also health trends in Saudi Arabia. Today, we turn our focus to how we define and measure what truly matters in healthcare. As Peter Drucker famously said, you can't manage what you can't measure. In this session, titled Measuring What Matters, the Power of PROMs and PREMs, we will dive into the significance of patient-reported outcome measures, commonly known as PROMs, and patient-reported experience measures, PREMs. Our aim is to explore how robust measurement tools can guide policy decisions and enhance the delivery of healthcare in Saudi Arabia. We are pleased and honored to have with us today in the first segment in today's session. We have Dr. Sarah Al-Munif, Director of Measurement at the Center for Value in Health and the National Project Manager for the OECD's Paris project in Saudi Arabia. We have also, the first segment, we have also Hadil Filimban, the Provider Affairs Senior Data Analyst at the Center for National Health Insurance, who will share her experiences and lessons learned from PROMs and implementations with different clusters she had worked with. We have also with us Fatima Al-Hassan, Patient Experience Director at Al Musa Health Group, offering her perspective on how measurement frameworks can drive healthcare improvements. And also the second segment, we will talk about the strategies and lessons learned from feasibility study. We are also honored to have with us today Daniel Hage, Senior Advisor at the Council of Health Insurance and an experienced healthcare specialist. In his role, Daniel leads the implementation of standardized patient-reported measures, PREMs, PRMs, and works closely with the Value-Based Healthcare Committee. We have also Dr. Wasim Shahad joining us today. Pleasure to have him as well. He's the Research Director at HealthLinks, whose background spans innovative research across the UK's NHS, academia, and Saudi Arabia's health sector. Today's program will begin with a panel discussion on the implementation of PROMs and PREMs within organizations. And I encourage you, our esteemed audience, to actively participate by submitting your questions via the Q&A function and by upvoting those questions that you would like to be asked, and we will try to accommodate as many as the time allows. So without further ado, I would like to begin by inviting Dr. Sarah Al-Munif, who will give us a recap on the first session and kickstart the discussion on PROMs and PREMs from Paris. Dr. Sarah, the mic is yours.
Thank you, Khalid, and thank you everyone for attending this session. We're really excited to showcase what we've done to you. We really thank you for joining us for episode 2 of our webinar series, The Health Systems Deliver, Measuring What Matters, the Power of PROMs and PREMs. And I'm really glad to have my colleagues with us that will showcase their experiences in measuring PROMs and PREMs within their organizations. Today's session, Measuring What Matters, the Power of PROMs and PREMs, will explore how patient-reported outcome measures and experience measures can transform our understanding of healthcare performance, not just from the perspective of providers, but the voices of patients themselves. As part of the global OECD Patient-Reported Indicators Survey, or PARIS, Saudi Arabia is advancing its commitment towards value-based care by putting patients in the center of health system evaluation. And this episode specifically will showcase how PROMs and PREMs are helping us measure what truly matters to patients, their health outcomes and their experiences, and how these insights can really drive improvement across our system. My name is Tara Mnif. I'm the Director of Value Measurement at the Center for Value in Health, and I'm also the National Project Manager for the OECD's Patient Reported Indicators Survey Project in Saudi Arabia. So before we jump into today's session, I'd just like to take a moment to remind you within the broader Do Health Systems Deliver webinar series. This series brings together insights from the OECD's Paris survey to reflect how well our health systems are meeting the needs of patients, especially those with chronic diseases. Through patient-reported data and insights, we can really paint a clear picture of healthcare performance and the perspectives that matter most to patients. In our first webinar, before Eid, we introduced the Paris Initiative and reviewed some initial findings from Saudi Arabia's participation. We looked at the makeup of our patient population, chronic condition trends, and provider profiles. Today, in episode 2, we shift our focus to the tools that give patients a voice, PROMs and PREMs. These measures help us understand not just where care is delivered, but how it's experienced, and whether it really leads to better outcomes. We'll explore their power in shaping high quality and person-centered care. Looking ahead, the next webinar will connect these patient-reported outcomes to health systems capabilities, helping us understand where improvements can be made. And finally, in our closing episode, we'll look outward, comparing Saudi Arabia's data to global benchmarks and learning from other OECD countries. So without further ado, today I'll give you a recap of episode 1, where we gave an introduction to the project and discussed the broad results about the variables. I'll then discuss the PROMs and PREMs that were measured in the survey and how we developed the Paris tool that measures the selected PROMs and PREMs. And then I'll show you the results of PROMs and PREMs measured from the application of the project in Saudi Arabia. So in our first episode, we introduced the OECD's Paris project and its significance in measuring really what matters most to patients to provide more person-centered care. We explored the goals of the Paris project and how it supports value-based healthcare by shifting the focus from clinical activity to patient-reported outcomes and experiences. Eventually, Paris will help us achieve the goal of providing person-centered care by international benchmarking, since this is an international survey with the participation of 20 OECD countries, which will help us in assessing how Saudi Arabia is doing among these countries, and collecting comparable data from different health systems on outcome measurement, which is a topic that's never been studied. This really helps policymakers understand how health systems are performing, where improvements and efficiencies can be made. We also shared early insights from Saudi Arabia's implementation of the Paris survey, focusing on these main themes measured, including practice type and location, access to care, the skill mix of providers within the clinic, the payment or reimbursement to providers working in the clinic, the digital information systems implemented within the clinics, care coordination, care plan use, and the provision of self-management support. The results revealed from patient characteristics, it highlighted the really high prevalence of chronic diseases among young adults and emerging trends in multimorbidity due to the worrisome lifestyle behaviors the population faces. In provider characteristics, it revealed the structure of primary care delivery, current service models, and the need to strengthen care coordination specifically. And in healthcare needs or trends, it really pointed to the fragmented nature of care delivery and the central role of primary healthcare in addressing long-term health challenges. And finally, we emphasized the need for standardization, validation, and national adoption of patient-reported measures across healthcare sectors. We concluded by reflecting on why this matters for policymakers, providers, and patients alike, and how the insights from Paris can drive more equitable, patient-centered, and a performance-driven health system in Saudi Arabia. A few more insights. From the first episode, so while the study broadly examines chronic care, participation in the Paris survey was not limited to patients with chronic conditions to ensure a more diverse representation of healthcare experiences and outcomes. As mentioned, of the key results of Paris was the very high prevalence of chronic disease in the country, especially in young adults. 70% of patients overall, aged 18 and older, had at least one chronic disease. 82% of patients aged 45 and older had a chronic disease, and 56% of patients aged 18 to 44 had a chronic disease. The most common reported conditions were arthritis or ongoing problem with back and joints in 30% of patients, followed by diabetes in 25% of patients, high blood pressure in 25% of patients, breathing condition in 11% of patients, followed by mental health conditions. 20% of respondents reported having multiple chronic diseases, so a very high prevalence of chronic diseases. So moving on to the main part of our discussion today, which is measuring health outcomes that matter to patients, or PROMs, and measuring the experiences of care, or PREMs. So this slide really summarizes the key domains measured by PROMs and PREMs, which are essential for understanding the healthcare from the patient's perspectives. These measures, again, go beyond clinical outcomes to capture how people feel, function, and experience care. For the PROMs that were measured, physical health, which assesses limitations in physical activities, such as, for example, walking, lifting, helping to assess the impact of illness on day-to-day life. Another PROM that was measured in Paris was mental health, which captures emotional well-being, anxiety, and depression levels, which is essential for holistic care, especially in chronic conditions. Social functioning, which explores how health conditions impact a person's ability to participate in family and social life. Well-being reflects overall life satisfaction and the psychological impact of living with a condition, linking health to the quality of life. And finally, the last PROM was general health, which offers a broad view of how patients perceive their overall health status, which is valuable for tracking progress and decline over life. The PREMs measured, there were 5 PREMs measured. First was confidence to self-management. So do patients feel empowered with the knowledge and skills to manage their condition, which is key for long-term health management. Care coordination, which assesses whether care is seamless across providers, which is critical for patients with complex or chronic conditions. Person-centric care, which focuses on whether care aligns with the individual's needs, preferences, and values, which is a cornerstone of value-based care. Experienced quality, so how do patients rate the care they receive, and was it respectful, timely, and high quality? And finally, trust in the healthcare systems, which measures confidence in the system's fairness, accessibility, the ability to meet needs, which is a valuable tool for system performance. So I wanted to focus a bit on translation of the tool, because this was a rigorous process that really highlighted the development of the survey tool used in the Paris project. And although it was developed in English across participating countries, translation and validation were critical for the success of implementation in Saudi Arabia. So the survey questions were extracted from other internationally applied surveys that capture PROMs and PREMs, including PROMIS, EQ5D, the WHO Wellbeing Index, the Commonwealth Fund surveys, and others. The new survey questions were designed in collaboration with subject matter experts to ensure clinical relevance and alignment with the core measurement domains. Countries then then had the opportunity to review and give feedback on the initial draft, which really helped ensure the tool was comprehensive and adaptable across the diverse health systems. Then each country, including Saudi Arabia, had the opportunity to add a set of country-specific questions, which helped contextualize the survey and capture local adaptations that might not be addressed by the core instrument. The finalized questionnaire was then translated from English to Arabic following a TRAP-D approach, where we translate, review, adjudicate, pre-test, and document to ensure really high linguistic and conceptual equivalence. And then finally, the survey underwent cognitive testing and cross-cultural validation, which was really crucial to ensure the responses were meaningful and comparable across different countries. This process really allowed Saudi Arabia to meaningfully participate in the OECD's international benchmarking, while ensuring that the data collected truly reflects the local patients' experiences. So I wanted to end with this. So these are the results of the PROMs and PREMs measured in Paris for patients with and without chronic diseases. This is the percentage of patients with positive outcomes, so the higher the better. But what is most notable is the worst outcomes and experiences for patients with chronic diseases, meaning that there's a really direct link with chronic diseases and poor outcomes. Another notable result is the very low rate of experienced care coordination. This is notably low in Saudi Arabia compared to other countries, which is highlighted in the international flagship report by the OECD. We can also see that although our mental health results were pretty high, the well-being was low, attributing to further psychological issues attributed to chronic diseases. Also notable, our self-management is on the lower end, and when we compare it with other countries, it's really lower than the average. This highlights that the low health literacy really of the population to manage their own health and well-being. So this concludes my part of the panel discussion. Thank you all for listening, and looking forward to hearing what my colleagues have in other organizations, how they use these measures to drive improvement in the field of outcome measurement. Thank you, and I'll hand over to you, Hadil, for your part of the presentation.
Thank you, Dr. Sarah. And it was a really great presentation, and it was a very great and insightful project. Assalamu alaikum and good afternoon everyone. My name is Hadi Filimban. I'm a senior data analyst here in CHI. I am currently leading the PROMs project. So our story started by a collaboration between CHI and Capitative Company, where they initiated a project since 2021 to implement the PROMs of the coronary artery diseases PROMs and the stroke PROMs, and they lasted for 1 year. They conducted a whole program which included hospitals in the MOH and outside MOH, military hospitals and university hospitals. They did a very great and insightful project, which they already presented that back then in 2022. And after that, in 2024, CHI started a new project where they reactivate the PROMs again, which will be potentially part of the cluster contract in the future, inshallah, according to the CHI scope of work. So we re-engage with these four clusters, which are R1, R2, E1, and Al Medina clusters, which involve 14 hospitals to implement the same project, CAD and stroke PROMs. So what we did first, we started with an assessment where we met with the leaders and executives to understand from them how was their experience during the Capitative project, and what was the challenges, and what did they think about the project and the PROM and all the pathways. We took that into consideration, and we started developing our own process and pathways. So the first thing we started about the data itself, how it will be collected, and how we can make it more convenient for the champions who will collect the data and the leaders to monitor and manage these pathways. So we standardized the process between us and them, and even internally, to know exactly how to embed the PROMs within their surface pathway. Consider it as a one rather than an external one. And we involved and engaged all the leaders within every step of the way, so they can provide us with their expertise in the field. So when we came across the implementation, it's two parts. First, we trained the staff, since they all new staffs, even the ones who were participated before in the project, they are all new staff. The training included an introductory about the value-based healthcare and the PROMs, and how to read and use the iCHOM reference guides and data directory as well. Moving to the data tool that we developed for them, how to use it as data collection, data submission, and the tracking tool. So they can know exactly every patient when to contact and when to PROM according to the iCHOM methodology. And also we gave them the skills needed to communicate with these patients in a way that it won't impact their answers. Explain what is the purpose and what is PROM and what is the benefit out of it. So until now, we trained 48 staff, and inshallah, in the coming weeks, we'll engage and train more staff and clusters in the same project. The goal is for the staff to be more familiar about the PROMs, the pathways, the surveys, and the question or the data itself. The second part of the implementation, it's a process itself that we standardize if it's helpful and it fits the system or not. So the cluster, they started collecting the data. We have bi-weekly huddles where we discuss their progresses, their challenges, or if they need anything. And also their voice are heard. So if they have any recommendations that we could fix or work in the process itself and how to manage it. They submit data. Some of the clusters submit data until now. We have a monthly report. The aim of the monthly report that they know how to improve their performances in the data collection and the data quality, especially when they have scenarios that they don't know how to deal with. Here was the time that we can discuss it. And for the quarterly report, we will try gradually to make an insight of the PROM itself until it reach a point where it can be used as a decision making or on future studies or so. And for the hospital, how they can benefit from it as an interpretation. As for now, this is not the end of our story. This is only the beginning of our journey. Hopefully, by the next months, until we reach that insightful reporting and publishing, the journey is completing. So the floor is open now. This is my end of my presentation, and if you have any question or comments.
Thanks, Adil. Fatima, if you want to go next and give your presentation.
Assalamu alaikum. Good afternoon, everyone. It's my pleasure to be here at this great webinar today. To be honest, there is a lot of things that I got interested in. I'll just wanted to give stick with the time limit. I wanted to mention that in Al Musa Health, all of the operations are based on strategic priorities, which are people, patient safety and quality, patient experience, promoting wellness, performance, and promise. If you could notice that the first three are related to people and patient safety and patient experience. I'll walk through each one of these and how these are being linked to PROMs lately. So any projects or anything that is going on in the hospital should be based on these strategic priorities. And also the values of the organization itself. The first one is human-centered care, which also focused on the experience of all the people who are working and visiting and being treated at the hospital. I'll just walk you through the journey of when or how did we start Plaintree accreditation. Um, um, I'm not quite sure if most of the audience here know about Al Musa story, but it started Al Musa Hospital started with a human experience. That's why we're really focusing and interesting on patient experience and human experience as well. So as soon as the hospital leader found that there was an accreditation named Plaintree, and he knows the story about how the founder founded this, got amazed about this. And there is a lot of similarities between Plaintree as an accreditation body to the hospital story and culture that is going on. So the journey started, but making sure that the culture itself would be maintained. And finally, the hospital got accredited with the gold designation back in 2017. And it was the first hospital that got designated with this designation in the Middle East. So this experience giving us until now is an eye opener to any change or anything that would be happening in the hospital should be maintained up to the levels of this gold designations. I'll give you some examples and some benefits of the PROMs that the hospital is working on. One of the examples is total knee replacements. So this is a PROM that the hospital was working on since I believe like 4 or 5 years now. But from this program, a lot of things, as you mentioned, Dr. Sarah, these measures and these PROMs and these percentages would give us numbers, but how to turn these numbers into an action on reflection of patients' experiences, the patients' reported outcomes. For it might be for the organizations as the hospitals, someone who would do a total knee replacement surgery would be successful if the surgery was without any complication. But for the patients, it's different. So the reason of the patients got in and did this surgery is pain level. Patient was not able to pray. He was not able. Patients are not able to do rukur. So the patient reported outcome gives us a quite, I would say, impression about their reported outcomes. And one of the things actually that we discovered and the hospital took an action about is that we launched an I would say like a mini gym or mini physiotherapy area in the same floor that the patients got admitted, so they can started their physiotherapy as from the second day after the surgery. So this was noticeable from the numbers, from the percentage of the patients' reported outcomes, and this is one example. Another example that the hospital also is doing. One of the highest percentage score is urinary incontinence. And all of us know that this is something really embarrassing for the females to announce that they have urinary incontinence after during pregnancy and after delivery. But taking this percentage and this embarrassment from the females and turning this into something that patients would be using, such as introducing and bringing physiotherapy devices that would help the patients to do core muscle exercises. Having a pelvic strengthening clinic added to the postpartum care. And also another thing is the postpartum depression. Most of the mothers, they don't know if they are going through the postpartum depression. But a lot of things was added to enhance this service, as of we would not be able to know that if we were not doing the PROMs. And because of these experiences, the hospital decided to do this year and focus more on PROMs for other diagnoses, like the chronic diseases that you've mentioned earlier. So these are like simple or two examples of the things that actual hospitals are doing this. This is purely implementing and enhancing patient-centered care, where we are adjusting the care plans to be personalized more on the patient's preferences and focusing on their journeys. Another thing is quality improvements, while continuously monitoring and improving the services in the hospital, also improving the clinical outcomes and patient satisfactions. So this is how PROMs being applied at Al Musa, and I'm open to any questions that I would receive from the audience later. Thank you so much.
Thank you. Thank you very much, Ms. Fatma, Ms. Hadil, and Dr. Sarah for your for the presentation and also your experiences and insights. And I'm sure those can drive the learnings from them and to enhance our health sector. I do have a couple of questions in the chat and a couple of questions myself that I want to ask you, but we'll defer that for the later after the second segment for the just for time's sake. And we are pleased to have, as I mentioned, Daniel Hage from Council of Health Insurance and also chipping in Mr. Dr. Wasim. He can you can join in also if you want to have any thoughts. So in the second segment, Danny will talk about the PROM strategy and the lessons learned from the feasibility study. Welcome, Danny, and the floor is yours.
Thank you so much. Thank you so much, Khalid, for organizing this again, and Dr. Sarah, also Ms. Hadil, Ms. Fatima. Thank you for your contribution. And of course, everyone joining this session, because I think it's really important that we keep doing this and sharing the experiences on all the initiatives in KSA, because one thing is sure, that measuring PREM and PROM, to keep it in the theme of this call, things are moving, things are happening, and we really want to see how PREM and PROM have an impact for our patients. So I will not use slides today because we had a discussion with the team of Value and Health, and we are very pleased to announce that we're going to have an extra session within the scope of these series of calls to fully focus for 1 hour on the outcome of the feasibility study, and I will briefly touch on that in a minute. I'm talking on behalf of myself and Dr. Wasim. Dr. Wasim is online, and if you want to join and tip in, please do, Dr. Wasim. But you know, we have launched the PROM strategy in 2023, and if I recall, we presented the impact, or let's say the document itself. We shared in an earlier call we had with all the members of the Value and Health think tank, and so I think most of you will have access to this strategy. I will leave the link to go to the PROM strategy in a minute in the chat. But 2023, we focused on how can we support the market by implementing a standardized way to measure patient-reported outcome measures for the first 4 conditions. And the 4 conditions are cataract because we needed an easy case. I think it's because it's, you know, it's very difficult. There is a learning curve, and it's normal to have kind of a learning curve as a country. So we added cataract because you have a short episode of care, you have quick results, and we are closing now actually a pilot on cataract PROM. So we hope, inshallah, to present this early June. Then the other conditions, and it really relates to what Dr. Sarah said, we have a very young population, but also reasonably unhealthy. So many people suffer from diabetes. So diabetes is one of the conditions, and because we know that also obesity is one of the causes of diabetes, developing diabetes on a later age and even young, we also included that as a priority disease. And because we have a very young population, pregnancy and childbirth is one of the 4 conditions we have in scope. Within the strategy, we defined disease-specific PROMs and generic PROM. I will not go too much in detail now on that, and you can read it back in the document. And again, I will share it in the notes in a minute. But to see where the market currently is, so is the market delivering and are we making an impact for our patients? We conducted the feasibility study in 2024. We are gathering now the final results, and the reason why we've done this feasibility study is, first of all, to see is there a need to update the PROM strategy? Do we need to go to other conditions? Where are we with the current conditions? So how many hospitals, providers in the private sector are starting to measure on those prioritized conditions and other conditions? And one of the learnings also during this feasibility study is that, and also Dr. Sarah mentioned this, the translation and the validation of the tool is a crucial step. And what we have learned is that there is a huge variation in the tools. Although they use the same, they focus on the same conditions, providers are using different tools. And for us as a regulator, that's kind of a concern, because if you want to build a national benchmark and ultimately use the data coming out of the PROMs and the PREMs in your value-based payment discussions later on between the payer and the provider, you need to, first of all, you need to unify the way you measure, and also you need to unify the tools or the measurement tools you put in place. So that's actually one of the biggest learnings during the feasibility studies, that the market needs support in the validation and contextualization, because let's not forget, translation is easy, not easy as easy, but it is kind of easy. But the contextualization, that's another thing, because the Saudi population is different than the generic Arab population. So we have other habits. We have other, like 5 times praying per day is very important for people. Walking the dog, not so much. So those kind of things you need to figure out the moment you make a decision on what tool you're going to use in order to unify those efforts. So the third thing we've done is, together with, and I almost forget to tell you this, that we've done the feasibility study with Presgeni with the support of HealthLinks. So Presgeni, I think most of you know Presgeni from the success story behind the PREMs survey we put in place in the kingdom many years ago, and they supported us to talk to providers to see where we are and what we need to enhance. So in the presentation in the beginning of May, we will take 1 hour together with them to present all the outcomes. And the other thing we've done is combining the PREM and the PROM. It's a little bit different than the Paris study. It's actually very different than the Paris study, but it had the same aim. We want to see if you can combine the generic PREM program we have now. Can you combine it with generic PROMs? So combining experience measures with patient-reported outcome measures. And I will not tell you too much now, but it seems that the outcome of the PERI study is quite in line with what we've seen in a very small study. And Dr. Wasim will definitely touch base on that in the extra session we're going to organize on this. And so things are happening, things are moving, and we also have humongous learning coming out of this feasibility study. And I'm quickly gonna repeat a few. How can we support its standardization? How can we focus on the translation and the contextualization of the tools? And we have sought support from ICHOM. And it was very nice to see that Ms. Adil also talked about the ICHOM primary data set, or the ICHOM sets, when they conducted their PROM journey for the conditions they had in scope. So ICHOM is, as far as I know, globally one of the only organizations next to PHO from the PROMIS tools, very well known. But they have actually came up with a 46, I think, for 46 conditions. They have now the tool sets in hand, but also the primary data sets they have developed. So the primary data set is something else than the PROM tool. The primary data set is actually looking at PREM, PROM, and CROM, so also clinical reported outcome measures. So what is the minimum data you need to measure for those conditions for all the patients in scope? We're going to start with the private sector, of course, but definitely, and this is the reason why we are so happy that we can use your platform of Value in Health to present this, because I think certain alignment needs to be done. And don't reinvent the wheel, as we say, right? We want to be agile and we want to move fast. So whatever we can learn from the public sector, we will definitely try to adopt in the private, and we hope it's going to be the other way around as well. So again, early May, we hope to have a special session on this, and we're going to give you more insights. We're going to also publish a white paper on the feasibility study done. The good news is that we see maybe you heard about the global hospital ranking from Newsweek. If you compare the list of this year, so it was data on 2024 compared with the year before, that we started with 3 private providers only, and now we have 15 private providers at a certain level, 2 ribbons and above. And that's quite an achievement, and we are very happy and very pleased that we see, and I can only talk for the private sector because this is what we regulate, is that we see that a lot of providers start to measure, and they start to measure in not only for one but different conditions. So that's good news. So we see that the market is maturing, but the market definitely needs help with setting the standards and supporting them with the right tools. I'm quickly looking at my notes. I think this is all I wanted to share at this point. And again, thanks for the team of Value in Health to give us the opportunity to be part of this. And if there is any question, I'm more than happy to answer these questions.
Thank you very much, Danny, for this extensive explanation. Especially, you've answered a lot of my questions. I had a couple of questions
Good.
for you, but you've answered them. So this is great. So just for the remainder of time, we're open to take questions also from the audience. And before we start, just to understand, because many of them are actually on the ground, and they notice things happening firsthand when implementing PROMs and PREMs. So always on paper, things look smooth, but actually in the implementation, there are challenges. And my question is for everyone to chip in terms of challenges, whether in the public sector, we have for example, Hadil or Dr. Sarah can chip in, or the private sector, we have Ms. Fatma, and also you, Danny, as well. So what are the common challenges that have been faced, and what did you do to overcome them? So we can start with anyone. The floor is yours.
I'll go first. So for us with the Paris project, and I see someone had this as one of the questions, but it was a cross-sectional study. It's been done as the first time and only time globally and nationally. So it was a bit challenging in the beginning to get buy-in of stakeholders. We were contacting both public, government, OGS, and private sector to participate in the survey. And since it was the first time it was implemented, buy-in was a bit challenging at the beginning, especially with the different methodologies each country was applying. It's an international survey. The OECD had us follow a few guidelines, but then it was up to the country to decide how it would be implemented. So it was a bit challenging for us to figure out the methodology for implementing a cross-sectional national survey of this. I mean, in the first webinar, I mentioned this, but we collected data from 15,000 patients, and that's a huge sample. Eventually, we got buy-in, but it was a bit challenging to explain the project, get buy-in. Collecting PROMs is a new idea, an innovative idea, and it was a bit it's a new think path for providers to contribute to. So that was challenging in the beginning.
Yeah, I always say ladies first, so maybe if Miss Fatima or Miss Adil want to add something, I'm happy to take this. Okay,
I'll just add something to what Dr. Sarah is mentioning. Sometimes you would face a resistance from the team because PROMs is a teamwork. It's not a one-person effort. So the team that will be working with you in the PROMs has to be aligned on the same goals. Having them, all the team aligned in the same goal is like, I would say, a first step and main challenge. If you pass this challenge, other challenges does not consider a challenge.
Yeah, if I can add something on system level, I think, and I totally echo the words of Dr. Sarah and Ms. Fatima. I think also alignment on, so from our perspective on a system level, is alignment on the conditions and alignment on the tools you use can be quite challenging, because of course every provider has his own clear interest to focus on showing the impact of a certain treatment, measuring before and after certain for certain surgeries or within conditions. But if you want to show the impact on national level, you need to have some kind of alignment, and that's why I really liked the Paris initiative, that you say, okay, for the primary health, for the primary healthcare, we're going to focus on this. Then this is one unified tool, and that's and even on global level, and that's a humongous success. Also from a technical perspective, if I see the challenges we had with this one pilot on this simple condition cataract, before we actually started with 5 providers, technical issues, building APIs to exchange data and so forth, bringing the survey portal tool, whatever EPROM or EPREM tool you use, bringing it to the patient. So yeah, a lot of challenges, and I really want to emphasize on what Ms. Fatima also just said is, because it's a team effort, is having all the noses in the same direction, we say in the Netherlands. It's like before you have convinced all the physicians and that they see the added value of this, that can be quite challenging. Yeah.
Thank you very much. We have another question. It's actually, I think it's very important that mentions, are there any the economic impact of PROMs and PREMs, and I think when you want to measure, also we want to measure the economic impact of itself. Are there any plans for it, and where do you see this going forward in terms of economic impact?
Yeah, definitely. It's I really need to be careful how I bring this, but the main reason why you want to start measuring the patient-reported outcome and experience measures are to improve the quality of life for and also to improve the experience for our patients. But in the end, you also want to use this data to see did we do a good job? Is the surgery or the type of treatment actually improving the quality of life for the individual patient? That means that you first need to start to build up a huge database and a huge benchmark to see this impact. And that's why it's so important that many providers need to start collecting this in a standardized way, so you don't have any debate on the quality of data. And to answer the specific in this question, yes, it will definitely, because if we talk about value-based healthcare, and if you look at the equation of value, it is the outcomes, clinical reported and patient reported outcomes divided by the cost. This is how you can really show that you did a good job, that we are investing in health for patients, and that we can remove fraud, waste, and abuse from the system. One thing you really want to combine, and that's what we are doing within CHI as well, is to focus on the patient classification. So the data maturity on the ICD coding, for example, is crucial if you want to measure at patient level. And we are also introducing now bundle payments and the DRGs slowly, gradually, and that will combined with the patient reported outcomes and the clinical reported outcomes, will have a humongous impact. But be honest, it will take time. It will take time to build up benchmark, to build up experience, and some people also in this call are doing the training with iCHOM, and I can really encourage everyone to do the iCHOM certified training. And then they say something very important: start simply, but simply start. So start small, and I think that our providers in this call can definitely emphasize or repeat this. You need to start somewhere simply, but you need to start, right? You need to start also to exchange the data and be very transparent.
Yeah, thank you very much. Absolutely. Especially with the data, it's very crucial in order to have a important decisions, and also evaluating the impact itself. It goes back down to the backbone of standardizing the coding and have a robust data collection methodology. This question, I think, it's possibly directed to you, Sarah. So it's looking at the future of the Paris project, and also it can be also for the PROMs and PREMs. So one question is there any policy initiatives after the implementation of the project? So looking forward, what are the things that can be built upon?
Great question. So for us, we just concluded the data collection phase a few months ago, end of December. So the data is just fresh. We're starting by taking the data forward to policymakers, providers, and decision makers to tell them, well, look at this, mental health is performing well or not well in these areas. We need to look at policies that are changing this. We're taking this to providers and telling them, hey, you're performing better than others in this area, but worse than others in this area. So you need to ramp up your care coordination. Your digital tools are not working as well as they should. So that's what we're trying to do. We're bringing the results to individual decision makers and providers that can change policies and procedures that are happening within entities. We're also taking the results on a national level and discussing them with policymakers for national policy change. The iCHOM project, what we call the PROMs implementation project, has been happening for a few years now. So I would suppose that their results are being taken further for policy implementation. Hadil mentioned that they're being in contracts and so on. But for pairs, we're starting to get that momentum on policy change going.
Adding to you, Dr. Sarah, I think as a payer in Saint Chai, once we have once we reach the availability or the possibility to use the PROMs and PREMs and value-based healthcare equations, and the budgeting will be very, very beneficial in the economy, as Mr. Daniel mentioned. I think this is the future, inshallah, for PROMs and Saint Chai.
Inshallah. Thank you very much. And one question they're asking is what is the prospect of having a national strategy for PROMs utilization in the public sector? So across MOH, holdco clusters and other governmental organizations similar to CHI's strategy. Are there any? What are the prospects that you could see?
So for us, maybe we concluded last session by saying that there's a huge need for standardization of these tools. We keep on collecting PROMs and PREMs results, but it's all being done on a micro level. Nothing's being done on a macro or system level. Just because, and by doing so, we can have a benchmark. We can look at improvement projects on a national level in order for improvement. There's no one size fits all when it comes to PROMs. So we urge different organizations to pick and adjust and make adjustments where they find applicable for their PROMs. But that's what we achieve to, and we strive to achieve a national PROM strategy for both the public sector and the private sector. That would fit both. Yeah.
Yeah, and for the minute of time, we have one final question, and I think it's a very important one. Danny went through it. However, it's very important to mention it again. So Danny talked about the not only the translation of the tools, but also contextualization of it is very important. So the question is, how can we overcome the cultural factors in Saudi Arabia that influence the collection and the interpretation of PROMs and PREMs data?
That's a great question. And from our experience, it was so since it was done only a one time, we had to make sure that the cognitive testing or the validation was really appropriate. As Danny mentioned, I mean, some questions that were that were in the international survey were really not applicable to our community. So, for example, we had to add praying. Our family ties are very strong, so we had to emphasize that. And in other countries, that wasn't emphasized as much. Other practices that were different in other countries aren't applicable to us. So eating habits as well. So we need local researchers to make sure that these tools are really valid and really applicable. We can't bring on international tools and just translate them and disseminate them within the country. So that was a main factor of the Paris survey, and I think that strengthened the application of the survey within Saudi Arabia. We had a very strong tool. It was an OECD tool extracted from other tools, so Promise, EQ5D, very strong tools, but we also had to translate them and validate them, which was a really important step for having a really holistic tool at the end.
Just to, if you allow me, just one short comment from the CHI perspective. We're going to start to do this exercise for the other three conditions than the cataract. And I totally agree with Dr. Sarah. You need to involve the local academia, and this should be an exercise you only need to do once. And this is why I think this initiative and future initiatives to align on conditions and which tools you use should be centralized, so you can build this national library, and then you don't need to reinvent the wheel again. That will definitely help. Yeah.
Yeah, definitely. And I think we're already on time. So I think that was the last question. I want to thank you all for the active engagement and the thoughtful questions for today. Our discussion highlighted the essential role that measurable patient-centered data plays in driving improvements in healthcare delivery. As we conclude today's session on measuring what matters, the power of PROMs and PREMs, I encourage you, the audience, to reflect on how measurement can be a catalyst for positive change in our health system. And I would like to remind you that this is the second part of the series. In the third session, we will explore more into beyond PROMs and PREMs, more specifically understanding care capabilities, which it will be held on April 23rd, so after 2 weeks, inshallah. So please stay engaged with us and follow us on LinkedIn to see the announcement, and also the extra one that Danny also mentioned, that we will have on early May, which is deeply focused. I encourage you to follow along. It will be a very successful one, inshallah. On behalf of the Center for Value in Health, I extend my sincere thanks to our guests, Dr. Sarah Mneef, Mr. Adil Filimban, Ms. Fatma Al Hassan, Daniel Hage, and Dr. Wasim Shahzad, and all of you for your participation. We look forward to continuing this vital conversation in our upcoming sessions. Thank you once again, and see you next time on Do Health Systems Deliver webinar series. Thank you very much.